Right, welcome everyone. Thank you so much for joining us for our second in our instalment of virtual seminars. Thank you in advance to our speakers in due course. I'm just going to run through a few housekeeping points with you all before we get going. For those of you that are new to joining our virtual seminars, we will be recording this. So if you miss anything, or if you want to share it with friends and family in due course, then we'll share a link to a YouTube of this seminar in a few days' time. We've got a Q&A function, so which you should all see on your screen. So please do, whilst the seminar is ongoing, submit any questions that come to mind. We've got a few pre-prepared in advance. We'll do our best to answer as many questions as we can at the end, but any that we don't have a chance to answer, we will follow up with and do our best to answer in due course. And now it's my pleasure to hand over my virtual microphone to Shelley, and I hope you all find it as enjoyable and interesting as we've found the ones that have happened so far. Shelley.
Thank you, Paul, and good morning, everybody. Thank you so much for joining us today. I'm the Chief Executive of Addenbrooke's Charitable Trust, a job I'm very privileged to undertake, no more so than during this past few months of helping the hospital through the COVID crisis. So it's great to be here today with Ashley and Lorraine, who I'll introduce shortly, but to share with you some of the experiences that the team in the hospital have experienced and actually what it's been really like on the ground during this difficult time. It's been a very busy time for the charity. We were supported so generously by the donors and the local community. We were able to raise over £1.2 million to expend in the hospital on areas that have helped during this period: items, technology, research, so many things that we will probably no doubt hear about through the course of this morning. So a very big thank you to you who have continued to support us and who are here today to hear the stories of the hospital itself. I think it's fair to say, and you know, I am biased, but I do know that the team have worked incredibly hard, and it's a fabulous team at Addenbrooke's who always go the extra mile to do things bigger and better for patients, and putting patients and staff at the heart of all of the activity and keeping them safe throughout this period has been paramount to the work of Ashley and Lorraine. And I really am privileged to introduce them to you today. So a big thank you. I'm going to hand over to Ashley first, who's going to share with you his experiences. Ashley's the medical director at the hospital and will tell you more about his role and what he's been doing. So Ashley, thank you so much. Over to you.
Thank you very much, Shelley, and good morning, everyone. I thought I'd start off by just talking through what the role of the medical director is. So first and foremost, I represent patients at the board of directors. So I am a doctor, but I represent patients, and I'm not the shop steward for doctors. I'm there to make sure that the patient care is paramount from a doctor's perspective. At the same time, I'm professionally responsible for all of the doctors here at Addenbrooke's. We have almost 750 consultant grade staff and around 650 junior doctors, so a total of around 1,400 doctors in the hospital, looking after around 1,000 beds. In addition to that, I have a number of specific roles. I'm the director of infection prevention and control, which, as you can imagine, has been quite a busy period for that aspect of my role over the last few months. I have a responsibility for patient safety. I'm in charge of all of the medical research I'm responsible for all of the medical research that takes place at the trust, for the education of the doctors and medical students. I have responsibility for the pharmacy and also for medical equipment within the trust. And those have been key areas that I just will talk you through some elements of what we've been up to. As COVID was beginning to circulate in the UK, the the number of cases first of all hit London, as I'm sure many of you will be aware. And we rapidly established a clinical advisory group, which was led by Dr. Jonathan Fuld, a respiratory physician, who led the team, and they met 7 days a week, even before we had a single patient. And they were rapidly assimilating information, creating some modeling data based on episodes of outbreaks in China and in Italy and then elsewhere around the world. And they were synthesizing the medical knowledge that was being rapidly published elsewhere, and in addition making personal contact with clinicians in those local areas. And they were doing that so that we could rapidly understand what we needed to do as an organization in order to organize ourselves to be able to cope with this upcoming surge of cases of a disease that none of us had ever seen before. And I give the example of perhaps Will Thomas, who's one of our haematologists, who very early on recognized that many of the patients were having blood clots and was able to identify the cause of this early on at the specific stage in the clotting cascade, and was able to rapidly disseminate the information for how they could treat these patients, how we could give prophylaxis. And within a week or two of the first case, he had published the work of not only the basic science, but he'd managed to get that into publication and disseminated it around to colleagues around the NHS. And it was that sort of work that was going on in lots of different areas at pace, at an unprecedented pace across the organisation. So this group were disseminating information, and that was driving the operational decision making at the start. So this was not a playbook that we could read from, there is no how to do it for this disease. We were having to work out what the disease was and then make the operational decisions as we went along. The second thing that we did that was perhaps very major in the organisation from a medical perspective was to reorganising the staff rotas. So just to try and understand the complexity, we run on any given day in normal times around 110 different junior doctor rotas across the organisation. And that's incredibly complex. People are on multiple rotas, people are covering different areas of the hospital. But as you can imagine, at times of COVID, the risk would have been that we would have had significant numbers of people absent from one or other rota. So we had to quite rapidly amalgamate many of the junior doctor rotas. We had consultants acting as junior doctors for significant periods, and we had a significant number of doctors who were shielding. So we brought in lots of academic staff from the University of Cambridge, lots of researchers, and we're extremely thankful to those. We had a small number of retired staff in key specialties. So I'm thinking in pediatrics and oncology, we brought some people back. And we created rotas that were more resilient, but covered larger numbers of people. So that meant that when we did have sickness, that we were able to cover those rotas. And then our doctors who were shielding, we found ways for those doctors to contribute, whether they were doing clinics at home, or whether they were triaging, whether they were getting engaged in research, prioritizing patients, checking whether patients had the correct assessments on the wards, etc., writing discharge summaries. All of those things were being done by doctors who were shielding. So people wanted to contribute wherever they were, whether they could be physically with us or whether they couldn't. So another one of the key areas that I think I'd like to highlight was the work undertaken by Professor John Bradley and his team in research. So much of the research that was undertaken were national urgent public health priority research studies, but in addition there were many that were set up and delivered by Cambridge, and we supported over over 30 research studies over the past few months, purely in COVID, which started up at a rate of knots. There was a weekly meetings of these research ethics councils to be able to start these things. And many of those projects were supported by ACT themselves, many of the local projects. To try and understand the scale, we've published from this organisation, we've already published over 100 papers relating to COVID since March of this year. And we've recruited 13,500 participants into COVID-19 research. And that's a combination of both patients and staff who've been involved in various elements. And that's a massive undertaking compared to what the pace that we would normally move at in terms of research. Another area of massive change has been pharmacy. So it's an area that one might not have thought of, but suddenly during this period there were national shortages of certain types of drug, particularly anaesthetic agents, etc. And as you'll have been aware at various times, there were various drugs that were touted as potential significant agents and then later dismissed. So there were huge issues with drug shortages from our existing suppliers, which meant that the pharmacy team had to be very nimble in sourcing drugs and providing drugs to other hospitals, providing mutual aid across the country. They were also having to bring in novel agents for many of the trials, drugs that have been repurposed for use from previous treatments. And then in outpatients, we made remarkable changes. So within a couple of weeks of the outbreak starting, we effectively shut almost all of our outpatients from physical face-to-face appointments, and most outpatients became virtual. As you can imagine, that with respect to pharmacy created huge problems in how our outpatient pharmacy, where people would traditionally queue up and collect their medications, would deliver. And I have to say that the in-house pharmacy team working with Roland's Pharmacy were able to deliver huge numbers of patient and medications to our patients across the county. And they've been doing that by the thousand every week. So it's been a truly remarkable change in practice for all of the pharmacy team in how they've done that and managed to keep our patients safe at a very difficult time. The next area, I think, which has received quite a lot of attention, has been testing. And as the World Health Organization leaders have said, that the key to success here has been to test. And on site, we have a Public Health England laboratory who we have worked really very closely with. At the very start, so one of our colleagues, Martin Curran, who works Public Health England, Cambridge, he developed a test for COVID that was found to be better than what was available nationally or internationally, and so we rapidly moved to that test. It was the most sensitive and predictable test, and we got that up and running. Obviously, there were challenges in terms of getting the volume of tests done in a timely fashion early on, but we worked very closely with Public Health England to ensure that we could maximise our capacity locally in Cambridge. And then a stroke of good fortune, or perhaps being in Cambridge, we were approached. We made contact with Professor Helen Lee, who is an academic at the University of Cambridge, who had set up a spin-off company called Diagnostics for the Real World a few years ago. And the premise of that company is a not-for-profit company to test patients in sub-Saharan Africa for HIV. So very simple tests that could be performed anywhere very quickly. And she had repurposed her machines by late March, early April, to be able to test those same people for COVID. So we very early on brought those machines to us. Within a weekend, we set up a whole new laboratory in the organisation purely to test patients for COVID. Using this test, this Samba test, we ran the trials to prove that it worked, and it meant that we could, instead of having our patients being tested with a turnaround time of 24 hours, we were able to get our output within 2 hours of the test being done. And that in itself then enabled us to manage our patients much more safely, to decide which patients had got COVID, which patients had other respiratory illnesses, and to be able to treat them appropriately. So that was a huge success, and that Samba equipment has been rolled out now more widely across the country. We've had a huge push in addition on staff testing, and here I think I'd like to thank Dr. Mike Weeks and Giles Wright from the occupational health team, who have been amazing. So what we have done is we worked with the University of Cambridge, again not using Public Health England or any other facility. We set up a testing facility purely for staff, both symptomatic and then asymptomatic, and that testing was done over within the University of Cambridge at the Jeffreyshire Biomedical Centre, and that was done on a purely voluntary basis by researchers from the laboratory over there. And that's enabled us to get up to testing 200 to 300 staff members a day, who were both, as I say, many of whom were asymptomatic. And what that's meant is over the period of time, we've identified around 55 symptomatic staff members. But in addition, we've identified a similar number of asymptomatic staff members just on routine screening, who we were then able to remove from the clinical area, get them to isolate. We were able to test and trace all of their contacts and their colleagues. And I firmly believe that's one of the key reasons why we've had such low infection rates at CUH. And it's why we've not seen any significant outbreaks over the period. We've had one tiny one involving one patient, but compared to what we've seen and read about elsewhere, this has been a huge success. And we've now undertaken over 13,000 tests on asymptomatic staff, and we're continuing to do that as we move forward to the winter, and indeed looking to expand the use of that. We've managed to set up, as part of the recovery programme, we have set up a huge staff testing facility over at Newmarket, and also there'll be another one coming soon on Newmarket Road, where everyone coming in for endoscopy, surgery, pacemaker insertions, all of those sorts of things, has pre-operative swabbing, pre-procedure swabbing 3 days before they come into hospital. And again, that ensures that they're safe to undergo their procedure and that our staff are safe. And then finally, we've undertaken a huge project to, again with ACT funding, to look at the serological tests, to test whether our staff have got antibodies, and to look at how that will work over time. So around 8,500 of our staff undertook that, and we found that the positivity rate was less than 8%. So some of the best outcomes for any hospital in the country, really, and certainly for a hospital of our size and for the amount of cases that we saw, really leading the way. And I think many of the things that have gone before have done that. But I think one of the key things here is that of those 8,500 staff, almost 8,000 signed up to take part in research on those samples, and to commit to come back for further samples, so that we can do real-time genetic testing on their samples, to understand why certain individuals had a serious response, a significant illness with COVID, and why some had none. And again, we've created a bioresource of samples that's available for use both locally and nationally, that's again a remarkable thing to do within 3 months, and we hope to be able to then take that research forward with our staff over the coming months so that we can really understand the response to COVID and how we can influence that with our treatments and understanding people's genetic backgrounds. As we move forward, the priorities for CUH are really to switch back on the non-COVID activity, and we are really trying to do that across the organisation as fast as we can, and we're trying to do that whilst keeping our patients and our staff safe and to build the confidence in our staff and our patients. But that's a huge challenge. We have more challenges with testing as we move forward into winter, and we'll see other respiratory illnesses being prominent. The challenge will be how to differentiate between flu and cold viruses and COVID, and we have plans in place to bring on different equipment and novel testing to be able to do that. We are restarting our non-COVID research, and we've already restarted over 200 non-COVID research studies. We normally would be running about 750 research studies at any one time at CUH, and we're looking to see how quickly we can get those all turned back on. And the challenge will be as well to bring back the things that, in addition to treating patients, we have a commitment to do research and to teach students. So we are currently bringing back our medical students and trying to get our doctors to get the experience that they need to have to continue in their training. And that tripartite mission of clinical, teaching and research is something that we really need to bring all back in, and to ensure that we don't forget those, because they're crucial to the future of Cambridge as a major teaching centre. Those were all the things that I wanted to cover. So I'm going to hand back to Shelly, but later on I'll be available for questions. Thank you.
Ashley, I think that's a life's work in 5 months that you've just talked about, and it's such a lot to cover. I'm sure we'll have some great questions to come back to. So thank you. That was fascinating. I'm going to hand over now to Lorraine, who alongside Ashley sits on the management exec at the hospital, but is responsible for our nurses, midwives and AHP groups. So Lorraine, over to you. Thank you.
Thank you, Shelly, and morning everybody. So as Shelly says, I'm chief nurse here at CUH, and I'm the professional lead for nurses, midwives and allied health professions across the organisation, which equates to around about approximately 4,500 individuals. And as well as being the professional lead, I have specific board responsibilities in relation to safe staffing and workforce planning within the nursing, midwifery and AHP professions, quality, safety and risk, patient experience, safeguarding and learning disabilities. I'm responsible for non-medical education and research and end-of-life care. So I was just going to touch on how the hospital felt during the pandemic, during the start of the pandemic, and then as we hit the peak, and then look forward as our next steps and priorities, much of which Ashley has already touched on. So I think when we first went into planning for what we was predicting high numbers of patients coming in with COVID to the organisation, I think it's fair to say that the hospital almost changed overnight, or certainly over a couple of days. Our activity changed completely. Our routine elective activity was stopped. Outpatients changed massively. Some of the research trials were stopped or significantly reduced. And consequently, we had a hospital that looked completely different. We had a huge amount of empty beds across the organisation, as less patients were attending even our A&E department at that time, probably because of all the media and how people were feeling quite scared about attending the organisation. So we did have, I was talking earlier around how on my clinical rounds, I went to one of our wards, and one of our paediatric wards actually, And for the first time ever in history, even at Christmas, we only had 2 paediatric patients on one of our ward areas, which actually did help us in the planning that we needed to do with our nursing and allied health professional teams, particularly at that point, as we needed to plan for what was a perceived or predicted surge in our critical care patients. So we undertook a huge amount of training, which I'll come on to later, as we redeployed our staff into different areas. So whilst some of the wards were closed and some of our patients were moved into different areas, the teams continued working, and the teams were trained to work up in different areas. Firstly, I would just like to say at this point that Ashley highlighted a number of these things within his presentation, but this was a whole hospital response. Everybody was aiming towards the same. We were all facing the same direction. We all had the same ambition. We were all working towards the same objective, which was preparing our organisation for what we were planning to receive. And just to say, I was massively proud of everybody in this organisation at how they responded to what was coming. Our staff at that point were, in some areas, incredibly scared. They were anxious about what was coming. Most people had never faced a pandemic before in their career and never faced anything like this. And there was lots of anxiety amongst all of our teams. So our first priority, one of our most important priorities, was looking after our workforce. Staff health and well-being was really, really important, a key priority for us. And that was not just physical safety, but also psychological safety. And Active helped us immensely with some of the psychological support that we've been able to offer to our staff. So we faced all of, initially at the beginning of the pandemic, we had lots of guidance being thrown to us literally on a daily basis. Ashley and I would come into hundreds of emails with different changes to national guidance. Particularly, I'm thinking I was leading at that point all the work around PPE. And PPE, as you would have seen from some of the media reports, changed constantly, literally. And we had huge support to put together different scenarios, different types of PPE that our staff should be wearing. We did huge training events for our staff, and everybody became involved. People that wouldn't normally, I'm thinking of some of our doctors, Dr. Gareth Corbett, who helped us develop training packages. Dr. Liam Brennan was absolutely joined at the hip with me, leading some of the work around PPE, and has continued to do so. Most of the anxiety that our staff were raising with us was about how do we keep ourselves protected? Can we have the right level of PPE? So that was incredibly difficult to start with. During the initial phase, we wanted to make sure that we had enough staff in the organisation, and we had people that were coming in to work with us that we rapidly deployed into areas. There was also a national push, particularly around nursing and midwifery students, that they became part of our workforce. So we had 129 student nurses and midwives who hadn't finished their training were able to come and do paid placements with us. And I'm pleased to say that most of those individuals will be staying with us now as permanent members of staff. We also had a number of returners to, not just to us, but to the NHS. I had a number of people, ex-colleagues that I'd worked with across different organisations during my career, that were texting me saying, can I come and do something? What can I do to help? The response that we had from ex-colleagues and the community and others was just amazing. People were desperate just to come in and help support the organisation. We then moved into quite a quick period where we had to redeploy our staffs to make sure that we had adequately skilled people in high acuity areas. So the prediction of numbers that we originally were looking at for COVID meant that we needed to increase our critical care capacity considerably. We needed to be prepared for, in the height of a surge, having around about 1,000 staff that would be trained to work in a critical care environment. And that's, to put that into scale, that normally we have around 200, 250 people that work in our critical care areas. This was a big, big undertaking that we were asking. Our nursing and midwifery and allied health professional colleagues were absolutely fantastic at volunteering to say, train me, what do I need to do, where do I need to go? And we had huge examples of where our clinical nurse specialists were trained to work in critical care, our research nurses were trained to work in different areas, and we had physios that were also working in critical care at the patient bedside. During this time, we trained 650 nurses to work in our critical care areas. 442 specialist nurses trained to go back and work in towards areas. So of course they are trained to work in areas, but this is a refresher course that we put them through really rapidly. And 674 nurses that had underwent some respiratory training. So the department, that our training teams worked tirelessly to ensure that we had appropriately trained staff to be deployed wherever they needed to. And you know, our staff just did that. Our staff really stepped up, which was just fantastic to see. And of course, it wasn't just clinical staff that were stepping up into being redeployed. We had huge amounts of our admin staff that worked in different areas. We had people from our audit departments that were taking on different roles. Some people went from audit to work into the post rooms. Some of our research nurses came in to work with our bereavement teams. So huge amounts of redeployment for all of our staff, and taking on all of their training, which was just amazing to see. We were delighted to have received so much support from our community and our local communities, and obviously through ACT. We were able to provide lots of staff facilities and support programs. So we opened the sanctuary, which you've probably heard about, which was an area for our staff to go and just have some quiet time away from the clinical areas, where they could have free drinks, free just some food over there, just some time to be away, so that they could just reflect on what they're actually facing, which was really, really important. The other thing I just wanted to touch on was our approach to quality. So obviously quality and risk sits under me, and a number of national reporting metrics were halted during the COVID period. But I think it's fair to say that whilst we didn't have to report externally, we still continued with all of our quality metrics internally, although we focused on different things. So as Ashley said, the huge amount of work that needed to happen in relation to infection control. We did huge amounts of work around our PPE compliance, training for our staff for correct donning and doffing of equipment, and making sure that they were kept safe in the clinical environment. And then also, if we just touch on our patients and our patient experience during this time. So we had to make a really difficult decision, which was hard for everybody in the organisation, for all of our nursing teams, particularly around stopping visitors coming into the organisation to keep our patients and staff safe. And that brought many challenges, as you can imagine, and it was very, very difficult for some of our patients, particularly if you imagine being critically ill, wanting to have your loved ones with you. I think one of the great stories that we've had is around how we had support from ACT to buy iPads for all of our ward areas, and I was able to share at board, with permission from the family, a story of a gentleman who was at end of life, and was only able to be with his daughters were only able to be with him through the use of an iPad, so they could be with him in his final moments, which just brings home how difficult this was for us all. But the use of technology during this phase was absolutely amazing. I think, as Ashley says, priorities for the coming year or the coming months really is about getting services back up and running. Our teams are now working incredibly hard, because whilst we had huge amounts of empty beds at the start of this pandemic, we have absolutely no empty beds now. And we are trying to treat as many of our patients as possible. And staff support now, I think, is even more important for us as we look at, you know, our staff have come through a very difficult period. So how do we continue to support them and keep them energised over the next few months? So we really are working hard to maintain some support for them and preparing them for what could be a second surge, as Ashley described. How do we keep those skills up, and how do we ensure that we have continue to have a flexible workforce? And I think finally, it's around, for us, it's about learning from what have we learned from this period. What do we need to do differently should we be faced with a second surge, however that may look? So I hope that's helpful. I'm very happy to take questions, but I'll hand back to Shelly.
Oh, Lorraine, thank you so much. I mean, it just goes to show the complexity of the hospital, and how in normal times, normally the hip bone's not connected to the thigh bone, because the disciplines all work very separately. And for everybody to come together, I think that's been something that I know the team at ACT have witnessed, is how everybody is just so focused, as you said yourself, on that common goal. And, you know, I'm sure that the questions will start to come flooding in for you guys now, but I just, you know, observationally, I think your leadership has been so important to bringing together those disparate groups normally and getting people to focus on that common goal. So from me personally, you know, I think you're awesome, but a massive thank you, because that, you know, that's inspiring. And you talk about the junior doctors that you're bringing in, and the, you know, restarting the teaching, the same for the nurses. There will be a future cohort of health practitioners and doctors who, you know, will have had some inspirational leadership to look up to and to learn from. So I think that's fantastic. So massive thank you. I know this is there's a lot going on for you guys at the minute, and we have had a question which probably lends to both of you, so I'll let you both answer it as you wish. But this question centres around, you know, you've done a lot of responding to the crisis, changing practice. How much of that practice that you've changed do you think you'll be retaining as the future normal practice, because you've learned how that improves the experience for patients' outcomes, you know, going forward? So I'm guessing outpatients, I mean, that pretty much was a deserted corner of the hospital for quite some time, Ashley.
Yeah, so if I could take that one, probably the biggest change has come within outpatients. As Lorraine said, within a couple of weeks of the outbreak, we'd almost stopped face-to-face appointments, and we have a number of colleagues who have only seen people virtually over the past 4 or 5 months, and the aim will be to continue that. So what we have found is that for many people, many patients, they find that actually a pre-arranged 10-minute phone call or virtual video conference, from particularly in follow-up cases, serves much better than actually coming along, sitting in a car, you know, parking your car, queuing up in a busy waiting area, things running a bit late, etc. What we found is that you have to keep to time when you're on a schedule like this, and it means that patients can have a 10-minute interruption to their day rather than having to take a day off work. And you'll remember that obviously many of our patients come very long distances for their treatment. They don't all live in Cambridge, so we see people from around the east of England and wider, and so we're aiming for around half of our outpatients to be done virtually, either by video or telephone. But we do recognise that we will need a mixed economy. Some people will need to come, but what we're going to try and do is to not make it a default that everybody turns up all of the time. So I think that's one of the things that we'll really try to embed, and that the delivery of medicines to those people in their own homes, we're looking to find a way to be able to embed that into our routine clinical practice.
I think there's been some unexpected benefits as well, Shelley. So things like how we communicate as an organisation has changed completely with social distancing and not being able to be face to face. But whilst we find that hard, because obviously naturally we want to be with people, I think we've found different ways. We have a fantastic comms team here, communications team here, and things like this. So being able to speak to so many of our staff through a Facebook Live session has been absolutely fantastic. Our staff, we've had really positive feedback from our staff. So those sorts of things that aren't impacting on clinical practice, but as a way that we can speak to so many different people at one time, are definitely things that we're looking at. How do we keep those? How do we keep that way of communicating with our staff for the future? It's been a fantastic way to get really key safety messages and quality messages out to people.
Yeah, I would comment on the communications for everybody who's not part of the hospital workforce. A daily, if not twice daily briefing that gave you an update on the number of COVID patients in the hospital in critical care, the number of patients who were being tested. It really gave you a temperature check for what was happening in the hospital, and the clarity of the communication was fabulous. And you talk about the other, the training, the testing, the face mask fitting, all of those kinds of things. There was always the right level of communication, and the team worked very hard on getting the same message out to everybody. So I think there's a lot to be congratulated on that.
Yeah, and just to add to that, the communications team created an entire website for all of our COVID information, so that the latest information could all be accessed by our staff members at any time. So if you needed to know anything about what research, what PPE, what the latest guidance on anything was, what was the latest clinical advice, it was all in one place that everyone could see, and everyone knew where to go for it. So and they created that again literally over a weekend. So that was fabulous.
Brilliant work, really brilliant work. Okay, I have a few more questions online. Dame Mary Archer, the president of Addenbrooke's Charitable Trust, previous chair of the hospital, is on the line, so it's nice to have you with us, Mary. Mary says, well done CUH and ACT for your inspirational work. So proud of you all. I'd be interested to hear about participation in clinical trials. Addenbrooke's was part of the recovery trial, I think. Any other smaller trials, e.g. of use of complement, any involvement in the planned trial of the DIO, Mary, you've given, Synvax vaccine. I thought you'd given me a difficult word there, Mary, but I think I've covered that. Ashley, can I hand that one to you?
Yeah, some good technical questions there. So we thanks for that, Mary. We participated in around just over 30 clinical trials, including some of the urgent public health ones, such as Recovery, that Chris Whitty, the Chief Medical Officer, publicised so much early on, and that's helped identify the steroids as a positive treatment, and hydroxychloroquine as not so useful. And so we've participated in those national trials, and then we've more locally set up other trials which are much more smaller in number, but aim to test the repurposing of some drugs and the use of some novel agents, and that's what Mary refers to there when she talks about complement activation. So complement is part of the immune response, and the idea is if we can control the immune response rather than treat the virus. Many of the problems from COVID appear to be where the individual's immune response is triggered excessively, and that in itself causes problems with the lungs, with the heart, with the brain, with the blood clotting. and so we've opened a trial which we're leading, but which will take part in other centres as well. Trials using that, and those trials are called the tactic trials. All trials seem to be able to work themselves into an acronym, but those are some very high-level trials that John Bradley has been key, working with Professor Sir Keith Peters, I know, former Regis and of Cambridge, and Sir Mark Walport. So huge national influence on some really nuanced testing of some very novel agents. And then we've been very involved in testing trials, and we've been involved so far with respect to vaccine. We've been involved with the Oxford trial, and so we vaccinated almost 500 staff members across Cambridge. That was us, Papworth and CPFT. So we participated in the Oxford trial, gave 500 staff members to that, and we are following those up. And I'm pleased to say I'm one of those people. I volunteered to do that. So every Friday I have to self-swab and keep going. So we'll see. But huge numbers of trials, and as I say, huge respect to Professor Bradley, who's led the amazing work in opening those trials.
Yeah, thank you, Ashley. I think just on the John Bradley, with the Research Advisory Committee that advises ACT on how to spend money on research, we were meeting every fortnight. And in normal times, when everybody's busy with clinics, we'd have maybe 10 to 12 clinicians who would come and join those meetings. And during COVID, there were many more who really wanted to be part of the effort to try and help, the research effort go forward. So there has been a massive amount of work on that. And here's a question from Simon Chapman, who asks about communication. But Simon, I think we may have covered that. If not, then do come back to me. But specifically, he was wondering how you knew what to focus on with regards to research or treatment, especially as there was lots going on simultaneously in other places. So do you have a view on that, Ashley?
Well, I think when it comes to research, we very much rely on the clinic. So the successful research requires the clinicians to identify a clinical question and that they feel needs to be tested. So we identified what clinical questions were being tested through the national trials and the urgent public health trials. And then the clinicians themselves identify where they see there is a gap in the knowledge, and that's where the ideas for the clinical trials come from. They come from the clinicians themselves, and then they come forward to people like myself or John Bradley, and then they put forward proposals for what research that they would like to take forward. But it's about it's the clinicians themselves identifying where we have gaps in our knowledge, and then taking that forward.
And there's a national register of all research, isn't there? So that you can see,
yeah.
I mean, I know there have been trials that we've supported from the charity that have been going on in other places, but the hypothesis was slightly different,
yep.
Subtle nuances. So, okay, that's great. One for you now, Lorraine, I think. Tracy is asking how it was decided which patients went to CUH and which went to Papworth. Are there any changes to the plan in the event of a second wave? And before I'll let you ruminate on that, Tracy says, P.S. I had to go to outpatients this week, other appointments online. It all felt very safe, so thank you for your hard work in allowing this.
Oh, that's good. Thank you, Tracy. I think well, clinical need was around how it was decided that patients would go either to us or to Papworth. So Papworth offer an ECMO service, which there'll be certain patients that would need to be transferred into Papworth. Ashley's smiling because you can ask me technical questions now, aren't you? So Papworth would take patients from across the country, not just from us, if patients required that treatment. Mainly our patients would have stayed with us and gone into our own critical care areas. I don't think we transferred out at all. That's how the patients would be decided to go there. Sorry, Shelly, there was a second part to that question.
It was whether there would be any changes to the plan in the event of a second wave.
I think, well, in relation to placements of patients, probably not. We're looking at, we would be classed as a regional surge centre, so we would have increased number of critical care beds. And in terms of nursing staff, we are still planning to staff our areas as we did during the peak for COVID. So we've had a number of staff, as I described in the presentation, that we have trained to work in critical care areas. Nationally, the staffing model for critical care changed during the surge period. So instead of requiring a one-to-one critical care trained nurse, it was complemented with other people that were trained to work in that environment, but not necessarily who were critically care trained. So we are continuing with that training program for our nursing staff. And you know, that we're just preparing should we need to increase our critical care beds.
Okay, so Simon Boyd has asked the question, what sort of planning do you have in the event of a second spike? That talks to some of it. Is there other planning that's going on right now, views?
Yes. Yes. Yes, broadly, there are a number of models that we see going forwards. So we obviously have a series of models depending on how many patients might come into the hospital and when that if and when that surge were to happen. So we sort of plan for different scenarios, and what we've done is organise our wards and our testing facilities, etc., to be able to cope with various levels. So we've organised our doctors and our nurses to be ward-based care, so we minimise footfall between different wards. So we do things that would reduce any risk of cross transmission. We do a lot more testing than we ever have done. We're training nurses and other professionals to be able to work in the critical care and theatre environment, so that we have a more flexible workforce. So we don't know quite how big, obviously. We don't know what will happen as we move towards winter. We don't know what will happen as the universities reopen. I think the schools will be a safe thing, but what we will probably know is that it's likely that if there are increased number of cases, as we've seen in Manchester and Leicester, that you'll have local lockdowns early on to aggressively to protect the NHS. And what they've seen in those areas is they haven't seen significant numbers of patients being admitted. So the numbers that they were detecting weren't leading to massive numbers. So I would imagine that if that policy were to continue, that we would be able to manage the numbers through local lockdowns, and so that the second surge, if it happens, wouldn't be as large as the first surge, and certainly wouldn't be a national thing. So we'll wait and see.
I think actually the testing will really help us in a second surge. So, you know, before we were patients were coming in and we didn't have that testing processes in place. We didn't have those pathways in place. But I think for a second surge, we are far more prepared because of the journey that we've undertaken over the past few weeks, really.
Yeah. So if you come in now, you're tested when you come in, irrespective of whether you have symptoms. You're tested if you're every week that you're in, and if you were to go back to a residential home or nursing home, you would be tested within 48 hours. And in addition, as I said earlier, the staff are offered testing, whether they're symptomatic and asymptomatic. So we're looking at large numbers of people that we're testing now.
Yeah.
Okay, that's great. Now, this question comes from Julia Boyd, and her question is, what part has CUH taken in developing max vaccination?
Yeah, we don't. So the University of Cambridge don't have a research interest in vaccines in the same way that Imperial and Oxford do. So they've led the way in sort of leading the vaccine development in the UK, but we are participating with them in their clinical trials. So as I said, we've participated in the Oxford trial already. We would anticipate participating in the Imperial trial when that comes round, which I think will be in October. But we await that. So we're participating in the vaccine, but we also are developing plans for how we would vaccinate large numbers of people in and around this campus should the need arise when the vaccines become available.
Okay, that's great. So moving forward, we've got a couple of questions now that are very similar, so I will merge them together. This talks about how we service patients who have had COVID and who are in recovery. So the question is, how will you determine what the right mix of face-to-face versus virtual appointments is for those COVID recovery patients? And how will you identify where face-to-face care is still needed or most beneficial?
So what we do there is the individual clinicians and senior nurses who are running those clinics, they will be the people who make contact with their patients, and they determine whether it's face-to-face or virtual, and that level of support is up to the individual clinical teams. Whilst we have an overall aim of around half of our clinic follow-ups being virtual, that's not going to be 50% in every different specialty. It may be 80 or 90% in some, but maybe only 10% in others. With relation to COVID, we have set up a group comprising intensive care specialists, respiratory specialists, immunologists and others, and neurologists to actually follow up patients with COVID. And again, they're learning as they go along from those patients. And it's a very individual thing as to what follow-up each patient needs, because as we've seen, some patients have come in and gone out and didn't really need anything, they've been perfectly well and don't need any follow-up. Others are left with quite debilitating illness with lung disease or blood clots or strokes, etc., and they will need more extensive follow-up. So it's very much tailored to the individual. This is not a one-size-fits-all. So I would use the example of, if you've had a heart attack, you go onto an exercise program for the number of weeks afterwards to get you fitter again. That's not the case with this. It's very much an individual, tailored approach to how we look after those patients.
And Shelly, could I just add to the face-to-face and the outpatients? We are very much working with our patients to make sure it's the right thing for the individual patient as well. So we're not just saying that it has to be a teleconference or a telephone conference, that we are trying to involve our patients, and we are collecting patient feedback on whether this works for our patients. So far it's been incredibly positive, but we are watching that and making sure that we are capturing what our patients feel about that is a way we communicate with them.
So if I've heard correctly, the general rule of thumb is that clinically you're hoping for 50% of patients to be seen virtually, and getting the balance right will depend on the discipline or the area of illness and the individual itself, which sounds like a great method. And just to follow up on the COVID rehab, I know that Dr. Miles Parks has set up some research. So one of the things that the charity are also supporting is research about how patients recover from COVID, so that should this be something that hangs around for a while that we don't find the right vaccine for, becomes part of the disease mix, that we can learn and look after patients both in recovery, and what we learn in recovery, how we might treat them at the very outset. So it's a complex world you guys run at the hospital, isn't it?
I think the key there is that this is a new disease, and what we're striving to do is to ensure that everything that we do, we try and learn from and sort of codify and really make sure that we make the most of it. And so rather than just do something, but actually try and do it in a structured way that we can then learn from, pass on to others what works, what doesn't work, and how can we make it better.
So how do we make sure that becomes part of the healthcare system for those people that perhaps weren't as serious with COVID and therefore not needing to be admitted to hospital, but are still suffering the effects of having had COVID? How does that become part of general practice, I guess?
And I guess that's the idea. We will disseminate the information out rapidly, as we've already done with the sort of over 100 papers already done, but we also liaise very closely with our general practice colleagues, and so we give advice and guidance to our colleagues in general practice all of the time to help them. So where I would imagine if someone was out there in the community and they had some post-COVID issues and they weren't already in contact, they probably see their general practitioner who would see, assess, and make the right decision for that patient as to who might be able to help them out at the hospital.
Okay, that's great. I've covered most of the questions. There's a couple of questions around statistics and survival rates, which actually I think we'll take offline, because after speaking for so long, I know the pressure that it can feel like, and I don't want to put you on the spot for some statistics, but Stuart, just to let you know, I've logged your questions and we'll try and come back and answer those and make those available for everybody to hear. I think we've probably exceeded time now. If I could ask you both, just, you know, a couple of words that sums up the mood of the hospital and the staff right now, and if you've got any kind of lasting words to leave with the supporters who are on the call today. That's unfair, isn't it? I mean, I'm just going to say awesome, because I think you've done so well and worked so hard. People must be exhausted. So,
yeah,
I'll give Lorraine the last word. So I'll go first, and then Lorraine can have the last word. I'd like to thank everybody who's donated. That's been hugely helpful. I think the staff they have a mixture of feelings, as I think everybody else in the country does. I think they're a little bit tired of COVID, if you like, but they're tired because of COVID, the work they've done, the amount of work, and but I think they're at the same time immensely proud of what they've managed to achieve over the past few months. And then I think thirdly, they are concerned for their patients and how they can treat the patients that they can see on their waiting lists and their backlogs, and how they can get back to not necessarily normal, but to seeing the volumes of people that they were seeing before, and to get and that's where their concern lies for the future.
Thank you, Ashley. Lorraine.
Well, firstly, Ashley never lets me get the last word, so this is their first. But I have to agree. It's exactly as Ashley says. I mean, I've been out clinical this morning talking to some of our teams. There's there's some tiredness. Of course, the staff are tired, and we're encouraging people to have the breaks that they need and they deserve. And they are slightly anxious about what's still to come. They're worried about the patients that we haven't treated, but I think overall, and quite rightly, an overall sense of absolute pride at how they have and we have collectively dealt with what we've been through, and I'm incredibly proud to be here as chief nurse, and as Ashley said, a massive thank you to all of you. All of your support. It's been invaluable to us. So thank you all.
Thank you both. And I think pride is the word. I'm very proud of the community and how they've got behind the Help Your Hospital, and of the team and the work that we're able to do to support you all. So a massive thank you from us. A thank you from me for the audience and our wonderful supporters, because none of the work that the team at ACDO would be possible without both sides, the hospital doing the fabulous work and the supporters. So it's great, and I genuinely pray and hope that second surge is small and you're able to get back onto a balance. I know it will take some time to clear backlog, but hopefully the community will rally around and help by virtual conferences and things like that with their doctors and healthcare professionals. So massive thank you. Thank you, everyone. Paul, I'm going to hand over to you for housekeeping. Thanks again.
Brilliant. Thank you so much to our panel, Lorraine, Ashley, Shelly, for your time today. It was enormously interesting, enjoyable, humbling to hear what you said. And just add my own thank you to everybody that's been listening today. All of you in some way have supported the hospital over the last few months or weeks. Every donation, every time you share on social media, every fundraising event you take part in, every Zoom quiz you've enjoyed, whichever both may be, have helped to make this hospital even better. And know that when you overhear people saying what wonderful hospital Addenbrooke's is and how lucky we are to have it, that each one of you are part of the reason it's such a brilliant hospital. So thank you from all of us, and we look forward to inviting you to another one of these events in due course. And we'll follow up on all our unanswered questions in the next few days, and we'll be sharing a recording of this event that you can share with all your friends and family and pass to them to enjoy it and become active supporters in due course as well, I hope. Thank you, everyone.